Welcome to this special video on the care sector, an update. Recognition PR looks after a lot of clients in the care sector. Thankfully, clients that are not that contentious because they do some fantastic care work. Joining me is Tony Stein from Healthcare Management Solutions, which also operates a large number of care homes with over 3,500 residents and staff throughout the entire UK. And John Godden from Salutem. Now Salutem not only operates in care settings but also educational care settings for special situations. Let's talk to John first. Pick John up first because your care settings are very, very bespoke and specialised. Tell people what you do.
So I think people naturally assume that care homes are for the elderly, and indeed 75% of them are just that, for elderly residents, and they tend to be larger, between 30 and 100 residents. Ours are quite different. We look after adults and children with learning disabilities and physical disabilities. So our home settings are much smaller. Our average home size is about 6. The schools are larger, but again, compared to a regular school, our schools for people with children with diagnoses like cerebral palsy tend to be a regular school site, quite large sites, but they would only cater for about 60 children. So much less dense than regular schools, and our care homes are much smaller and less dense than what everybody imagines an elderly care home is like. And that does bring some advantages, particularly in terms of infection control, and also some different challenges, particularly around the use of protective equipment, as a lot of the people we look after have quite challenging behaviour, and indeed often they'll have difficulties in communication. So covering the face, for instance, creates not only a communication problem but heightened anxiety levels, which for people with severe autism, severe learning disabilities, can be quite a problematic issue. So, we have some areas where it's easier to keep COVID out of our homes, and then some issues that arise that make it more complex, but quite a different set of problems than those that would be occurring in the homes that Tony runs.
Okay, well, let's just talk a little bit more about your challenges. My daughter is a paediatrician and dealing with sick children, and she said the same thing about face masks. It can alarm children who are not used to that kind of thing and inhibit communications, but also instill a sense of unnecessary fear. So just let's talk about the headline issues and how you've tackled them.
So the headline issues are, the two headline issues are, number one, keeping COVID out. And the second one is, stopping transfer and sticking with the rules that come from Public Health England around PPE. So first of all, keeping COVID out. Now, we're used to protecting the people in our homes because, as a generalization, they are more sensitive to disease than the normal population. So in terms of flu control, norovirus control, those sorts of things, they're with us all the time. So we're reasonably well prepared for that sort of thing. And our staff, the hand washing thing to them was second nature. That's what they always do. And again, because our homes are small and the interaction with the outside world is more easy to control, our staffing numbers are lower than in a hospital particularly. Keeping the infection out has proven to be less of a challenge than it has in other settings. But what is more of a challenge is wearing PPE. That's very, very abnormal, except in a few of our settings where we have clinical work. And you can overcome it in a number of ways. You see an awful lot of social media content of people zhuzhing up their face masks, particularly for children, turning them into some sort of fancy dress is not a bad way of doing things. Although that's pretty hard to keep up over weeks and months. But that can sort of break down the barrier and get rid of fear. But the communication issue is quite a difficult one. We have got people who are who are non-verbal in their communication, and they do want to see a full face. They need to see a full face. So we have to do full risk assessments for those. We have to make sure that we are balancing the risk of spread of infection with the risk of supporting that person in an appropriate way. And it has to be done at a very granular person by person level. And we look after about 1,400 people, and that's a big job of work. And what it requires is your staff to be very empathetic and to be imaginative. And it's really great to see the staff score very, very highly on both of those points.
Okay, let's bring Tony in. Tony, the care home sector has had a bit of a shock treatment by the media. The politicians have been blamed for all your problems, but nevertheless, the problems have been amplified and focused upon by the media. Do you recognise the media's depiction of the problems in care homes when you look at your cohort?
Good morning, Graham. Morning, John. The simple answer is no, I don't. I think it's unreasonable for us to look at care homes and quote death figures as if this were something that was, if you like, created by the fact that we were running care homes. Remember that this is a virus that particularly attacks the elderly and particularly attacks those with underlying health conditions. So a care home generally today will be dealing with people who are generally very frail, very poorly. They're not like the retirement homes of old. A lot of our homes deal specifically with end-of-life care. So I would say it's hardly a surprise, and in fact it would be expected that the virus would have a disproportionately impact. It would be disproportionately impactful within the care home environment. That said, we were preparing very, very early for the virus, and we took a lot of steps very early on to prepare for what eventually came. We've got to remember, in our care services, we're looking after on average 60 people, and there are a lot of staff that by necessity have to come and go into that service every day because they've got their own families to go back to and to care for. So isolating and locking down in its entirety is just impossible. I mean, it really just is not, you're not capable of doing that. People have to come and go from the home. I mean, I've heard stories of staff moving into the home and living in. That's potentially doable if you've got one service and it's not so large. I'm not sure how long you would manage to keep that up, but normally you have people coming and going. So we sort of accepted the fact that we were going to have the through flow of some people. We locked down to visitors. We didn't lock down to visitors to see relatives at end of life. I think that wouldn't have been realistic or fair. But what we found is that generally speaking, our death rate has been higher than it would normally be at this time of the year, and that's on the basis that we've recorded everybody who died effectively unexpectedly but had some kind of symptoms as a COVID-19 death. So what I will say is to everybody that the death rates now being quoted in care homes are exaggerated. There will be people amongst those recorded as COVID-19 deaths who would have died of chest infections or other underlying health conditions rather than COVID.
And that's why the government wants to have this global death total, or the amortized death total, comparing year on year later in the year, isn't it?
Yeah. I think what we've done is we've swung, haven't we? We've swung from only counting deaths in hospitals to now counting virtually every death in a care home where somebody had a symptom as a COVID-19 death. So we've swung from one extreme to another almost. And I think the media have latched onto this and are treating this as if this was a function of the fact that care homes are not a suitable place for people in this kind of epidemic situation. The reality is that those elderly and vulnerable people out in society would have been just as susceptible to the virus, if not more so, than in a lockdown environment where PPE is being worn and infection control is the natural sort of day-to-day sort of trained response to situations like this. So what we've seen amongst the staff is fantastic. It's been a very professional, a very thoughtful, a very proactive management of the situation for our staff. Just as John was saying, that the situation for people with autism and other challenging conditions, the wearing of PPE creates anxiety and fear. The same can be said for people with dementia. We're finding that again, is a challenge that we've got to try and overcome. But we're all learning through this process.
Okay, let's just.
The situation just requires cool heads and proper management. But there's always going to be more deaths within the care.
Let's just ask you both the same question. BBC Newsnight ran a report on Wednesday, the 6th of May, that was union influenced, and the union was saying that care homes routinely do not pay sick pay. This encourages, and according to the union, 12% of people who had COVID were considering going into work if they worked in a care home. And it was saying that the working practices and pay in the care settings encouraged a spread of the virus. Now, I know you can't talk for the entire sector, but what is each of your policies on sick pay? John first.
Yeah, we pay sick pay, and we in the normal run of things, you do not want people who are carrying whatever infectious viruses in a home, be that flu, be that COVID. You just don't. And in fact, we've gone further than that. And we have used, in some cases, the furlough scheme. So, we wanted to protect pregnant women, from it. And obviously there's anxiety around that. So we enabled them to be paid, in fact, full pay when not working. All of those who received the NHS letter, because, quite a few of our staff themselves have some underlying health issues, and we didn't want to expose them to unnecessary risks. So we allowed them to self-isolate on full pay. So, I mean, I'm sure that the care sector is big. It employs an awful lot of people. Figures I've heard is it's around about 1.6, 1.7 million. So of course you can't generalize entirely, but all I can say is what we do, and we think we're very fair about it. Now, the other side of the coin, of course, is that we don't run factories. We can't turn off the production line because we haven't got enough staff or because we're short on materials. We just that is not an option. We have to keep the care homes open and functioning, and our businesses, both Tony's and mine, is people looking after people. So we have to have the people to do that. So of course, whilst we want to ensure all of our staff are fairly treated, properly paid and protected, our overriding motivation is to make sure we have enough of the right, properly trained staff available to look after the people in our homes. And that is a hard balance to strike, but it requires trust on both sides. It requires our staff to trust us and us to trust our staff.
Okay.
If our staff say they're too ill to work, we got to take that as face value and support them, and that's what we do.
Tony, let's go to the same point with you. There's been a finger pointed by the media and by certain unions at your sector and its employment practices.
Well, let's just actually pick that argument apart, because first of all, we are testing our staff on a regular basis by taking temperatures and to ensure that they're not symptomatic. And so therefore the argument that symptomatic staff members are turning up to work, putting everybody at risk because of a financial imperative, doesn't hold water to me, because actually somebody who's turning up to work and symptomatic would be turned around at the door and asked to go home and isolate, as is the guidance. So I think that has to be a very politically motivated stance that the union were taking. I mean, I was a very, very early campaigner, and we made a decision very, very early on in this that anybody who was self-isolating for a period of 12 weeks for whatever reason, that were in the very susceptible category, I can't remember the words off the top of my head, but so we would pay them full pay, and just as John has said, because I think people can probably manage 3 or 4 days on statutory sick pay, but you certainly can't manage for 12 weeks on statutory sick pay. One of the things that I think this brings us back around to, which is that age-old nut, which is the funding of social care. The people that we deal with, I mean, predominantly 75% of the people that we look after in our care homes are funded by local authorities. And the local authority rates for looking after people 24/7 are generally very, very poor. And certainly the sorts of money we're talking about are very different to the kind of funding that John's residents would receive. And that doesn't make it possible for us to pay full sick pay to everybody who's on sick. It's not financially doable. And we would love to do that, but I think that's a completely different argument. I think the point that the union was making, however, was very politically motivated, and people turning up to work with symptoms would have been turned around at the door. The difficulty, of course, comes when people are transmitting the disease and are asymptomatic. But then that part of the argument doesn't come into it, because if you've no symptoms at all, then you turn up for work anyway. So,
well, that goes to my next question to both of you, and that is testing. How would you like to see the testing regime work? Is it working as it is? And would you like to see changes in your own settings?
Well, can I just come in there? Because one of the things that I have seen a lot of in the last couple of weeks, particularly in the elderly sector, operators pounding the table and demanding more testing, particularly demanding more testing for staff and asking for these pop-up test centres to come to the homes to carry out the testing. Now, one of the main concerns that I have is what would actually happen if a test centre came to our home, tested all the staff, and they all tested positive. Now, that's a very difficult question to answer. You know, we suddenly have to, under the guidance, self-isolate those people for 7 days from the date of the test, which leaves me with no staff to look after the elderly residents in the home. And, you know, we could bring in agency staff, but they don't know those residents. They don't know their peculiarities and their health issues and so on, which puts them at greater risk. So that's a conundrum that we're battling with at the moment. So I think what I would say is that testing may help in terms of gathering data and tracing and so on, but it actually brings with it its own little problems. And this virus is a challenge. It's a real difficult thing to grapple with, and there are no easy answers. There are no easy answers, and people that are looking for those simple soundbite solutions are misleading themselves, because there are none. This is a difficult time, but you've got to think it through and work through the best possible of the outcomes that are ahead of us.
John, what's your view on testing?
Yeah, I echo some of what Tony said, but I have a preference for knowing rather than not knowing, and then having a plan A, a plan B, a plan C, and indeed a plan D. There is no simple solution here. We have had testing ramp up over the last few weeks, and one very interesting pattern that's taken place is that of all the staff that we've had tested, 8% are positive, and the ones we've been testing, to begin with, because obviously we're prioritizing how this is done, are the ones that thought they had symptoms and thought they had exposure to COVID. So an 8% positive test rate, I mean, we're quite surprised how low that was, and obviously that has enabled us to plan properly and plan better. That could change, and we've got strategies for dealing with that. But I mean, Tony raises a very valid point, and it reflects what I said earlier about these are not factories that you can just turn off. You've got to have staff available. We've got 130 services, and we've kept COVID out of 128 of them. And I will caveat that because our services are small, and the way they're set up, it is easier for us to maintain that than some of the stuff that Tony and others have got to deal with. But the two that went in, one of them sadly did end up with one of the 6 residents there had COVID and sadly passed away. But she had lots and lots of other health issues as well, and COVID was a factor, and she is one of the statistics. And it's very, very sad for the people involved. She lived in that home for 15 years. But incredibly, the staff there, particularly the manager, was convinced that she had COVID. And this is some weeks ago before tests were available. And her mindset was that she was absolutely going to carry on caring for this individual. And, she did, she felt not great, but she and the service user isolated together. Mm-hmm. So they cut themselves off from the rest of the home, very, very protected. Nobody else in the home ended up with COVID. And that's the mentality of lots and lots of care workers. That's really how they think, and the values that they bring into the job are incredible. And if there's one thing that's come out of COVID, which is a good thing, it's everybody's acknowledgement that the human values of a lot of people in care are quite incredible and extraordinary. But what we have to do as a company is we have to support her, that manager, with her decision making. We have to support her in whatever she wants to do. So I wanted to know whether she had COVID or not, and she didn't want to know, because then we could enable her to plan. She was absolutely paranoid that if she was found positive, that we wouldn't allow her to care for that poor girl who eventually passed away. And that can't be always the answer. We would have risk assessed that. We'd have looked at what was possible, and we would have probably, with everybody's consent, allowed her to continue the care and avoid the spread that way. But, these are the sort of things we're having to wrestle with. But let's be clear, we wrestle with not dissimilar things to this on a daily basis in non-COVID times. And this is where we've got to avoid this paranoia creeping in and this politicization of things. And they're taking normalities as being trying to prove political points, and that's ultimately very, very damaging to everybody.
My last question to you both, maybe a brief summary of where you see the future mid-term, maybe later in the year, September, October. Tony first.
Okay. It's very difficult. This is something that we've all been wrestling with. It's hard to see exactly where the virus will leave the sector. I have a feeling that for a lot of different reasons, there will be a lot of operators who don't make it, and we'll see a bit of provision exit the sector. Clearly, it's a virus that's attacked the population and the elderly particularly, so demand slightly reduced. I think the one thing that we all will learn from this is that this virus is out there now, and until we've got a vaccine, until we know that people are generally safe, there's going to be some element of social distancing and a slightly different approach to the way that we've operated, and that will run through certainly till the end of this year. So I think, for example, the normal routines of visiting and having entertainment and all the rest of it, that will change, I think, in the medium term, for definite.
Okay.
And certainly the way that I do think, I agree with John. I think if there's any positive comes out of this whatsoever, I think it's that the general public's approach to social work, social care, I think that has changed. I think people's perception is now very different.
There's a heroic element to it. John, what do you think the medium to long term is?
I think, picking up on that point, I think the appreciation of what is done has changed remarkably, and long may that continue. I hope that follows through with more resourcing. We would love to pay the people who do such remarkable jobs more money. And that has to come from the source, which in our case is ultimately government. The value of what is being done has really sort of come to the fore. So that is a positive. I think our sector, adult and children's specialist care, is going to change probably less from a scale perspective than elderly care, certainly in the short term. I think we're reasonably unaffected. But I mean, the lives of the service users we have and the kids in our schools and students in our colleges, they're always magnifications of everybody else's problems. You know, if you've got cerebral palsy, your everything you do every day is sort of 10 times harder than everybody else's actions. You know, everything from getting yourself dressed to having a cup of coffee to attending a lecture. It's harder. And I do think that some of that, you know, every member of the population is going to find that a lot of their actions are going to be twice as hard as they were. You know, queuing at ASDA, whatever it is. And you follow that through to the lives of the people we look after, and some of the activities that they do are going to be 20 times harder. So that is going to create challenges and restrictions, but we'll get through there, and we'll find the balance, and we'll find the way to do that, because everybody knows that it's important. And you know, our sector is the only sector that's actively employing it at the moment, and we're attracting some very good people with the right values to come in. So that's a positive, and that is going to help us normalize as fast as we can and deal with the new normal.
Well, can I just thank John Godden and Tony Stein? A sobering discussion. We'll have more discussions on these LinkedIn channels in the weeks to come.